Hi guys, welcome back. The next topic at the agenda is scleroderma, also called as systemic sclerosis. Most MCQs of this topic will begin by describing a female patient with positive antinuclear antibody. You see, the examiner will be bluffing before you because he wants to draw your attention towards possibility of wrong diagnosis as SLE. I've already emphasized to you that antinuclear antibody can be positive not only in cases of SLE but even in scleroderma. It can even be positive in rheumatoid arthritis. But the percentage accuracy for diagnosis of rheumatoid arthritis would hardly be 30 to 60%. I would once again like to bring to your notice this table that I've already shown you in the discussion of SLE, where you can notice if I zoom in, you will find the 95% accuracy for antinuclear antibody is valid for not only SLE but even for Sjogren syndrome and even for scleroderma, both the diffuse variety as well as the limited variety. So I definitely want you not to get biased by this terminology. Now, coming to the main discussion, this particular topic will begin by describing this lady whenever she's putting her hands in cold water. There is going to be an exaggerated vasoconstriction of the blood vessels of the tips of the fingers, resulting in they becoming almost pale or white. Subsequently, what's going to happen is that there's going to be a accumulation of deoxygenated hemoglobin that will give a bluish color to the fingertip, and later on there would be an exaggerated vasodilation contributing to the tip of the finger to become red. You see, you're all aware of this. We call it Raynaud's phenomenon. Instead of putting hands in cold water, he could also describe a patient living in a foreign country, like countries like Russia, or let me say Canada or America. They're fairly cold countries. So when you go out, you have to wear gloves. Now this lady, she went to her car to maybe go to the grocery shop for shopping, and she forgot to wear her gloves. When she went out in this extreme biting cold, we all know that biting cold can contribute to frostbite, but today I'm mainly emphasizing regarding the feature of Raynaud's phenomenon. I said three things here. First, there is a exaggerated vasoconstriction causing the tip of the finger to become white. And I also want to tell you that in some cases, Raynaud's phenomenon can be painful also. The phase that will be painful, however, will not be the pale or the white one. Like in this image, you can see that the patient is having rather paleness of the tips of the fingers. As the concentration of deoxygenated hemoglobin in this localized area will rise because blood supply to this area is lesser. Deoxygenated hemoglobin more than 4 gram percent. I know you will say some books say 5 gram percent. That's always a range. I mean, we cannot have an absolute value. That is when cyanosis would come. This would be a peripheral cyanosis, and this peripheral cyanosis will not respond to oxygen. You see, normally we study peripheral cyanosis response to oxygen, but that is the one that is going to be caused by shock circulatory failure. In this case, it's definitely due to the deoxygenated hemoglobin secondary to the decreased blood supply to the tissues. Now you will be having an exaggerated vasodilation. That is where the pain component can be perceived by the patient and the tip of the finger will become red. We call this as a Raynaud's phenomenon. In fact, I want to tell you that this is studied even in surgery, and sometimes they might use terms like primary Raynaud's phenomenon and secondary Raynaud's phenomenon. I want to tell you that for the primary variety, if no cause is found, suppose you are having a patient with Raynaud's phenomenon, see from the impression of this particular discussion, you will get a feeling that Raynaud's phenomenon is seen in scleroderma. I want to tell you it can be seen idiopathically also. This idiopathic one is referred as primary, but the secondary one will always be associated with various connective tissue disorders like scleroderma that is being discussed at the moment. In fact, in the later stages, this may even be the secondary one I'm talking about. This may even be associated with ischemic digital ulcers. So, in a person who's having primary Raynaud's phenomenon, you will never have ulcers on the tip of the finger. But the secondary one, ischemic digital ulcers can also be present. So, like I have described digital ulcers in polyarteritis nodosa, again in the rheumatology section subsequently, I want you to remember ischemic digital ulcers may be present, not always a case. If you make an early diagnosis, obviously you would not let this happen and start treating the patient. But yes, this may be written even in literature of the current topic that we are discussing. I want to highlight the fact that sometimes in surgery he might use the word Raynaud's disease. You see, what I was teaching you was Raynaud's phenomenon. When you read the word Raynaud's disease, it basically means idiopathic variety. It means it would be seen even as a harmless benign condition and most of the time would not cause any disability. Just to make you more comfortable with this information that I've highlighted, the primary and the secondary one, because I usually have students complaining, sir, it's difficult to remember. I'll try to give another example, and then you guys tell me, would you like to call it primary or a secondary one? You see, suppose you are having a construction worker. This guy is using a drill machine, and drill machine to drill a hole into rocks, like metro work would be going on in many cities in India. So these guys would be drilling holes into the rock, right? So the vibrations produced by the drill machine can definitely contribute to Raynaud's phenomenon. Or I can give another example. This guy is again in construction business, is using a big hammer to break the rocks. So the vibrations that are produced in the hammer every time can also contribute to Raynaud's phenomenon developing in this person. So I'm using the term hammerhead. Or let me say there's a guy working in the dockyard on a heavy duty crane. Now this crane is used to lift up heavy weights. So he will have to adjust the tension in the cable that is used to lift the heavy weight by changing the gears in the gearbox. So the vibrations of the big engine of the crane will be transmitted to the gearbox, and from there to the hands of this guy. And therefore I can say that even this crane operator might be complaining that when he goes to work and when he's changing the gears, as I highlighted, to adjust the tension in the cable, that is when he's having this Raynaud's phenomenon manifestation. Because there is a cause associated with, even if it is occupational, but at least you know now that there is a cause. If there is no cause documented, if it's idiopathic, that's when you write the word Raynaud's disease. But lots of time you might be getting even Raynaud's phenomenon of the secondary variety in male patient also, and that male patient is not having any rheumatological disorder. This guy is actually into construction business, and that is contributing to a secondary manifestation. The bottom line, the carry home message for you is, primary we will not be able to determine any cause, whereas the secondary one can even be associated with digital ulcers in the later case. Now before I go into more explanation for Raynaud's phenomenon, I would like to give you a contrasting presentation. So I'm just zooming in, and please listen to this discussion a little carefully. You see, in winter season, we, especially in North India, it's gonna be biting cold. If you go towards Punjab, or if you go towards Jammu and Kashmir, it's gonna be very, very cold. So people will be using heaters. And person is sitting, like, let me say a lady, she's sitting near the heater, so that I mean, in a very cold winter, your toes will feel cold even when you're wearing woolen socks. So this lady, she's sitting near the heater, and her complaints are that when she keeps her feet near the heater, due to this heat exposure. See, earlier I was saying cold exposure, no. Now I'm saying a lady is saying that when she's sitting near the heater due to heat exposure, she notices that the toes of her feet will become red. Well, that can happen with all of us, no. If you are keeping your feet near any heat source, the vasodilation component will make it relatively red. But here she says, sir, it becomes red, so red that it sometimes looks almost violet, and in some cases even it might be having a purple appearance. So this time I have changed the color appearance, that is red, violet, purple. They may not occur in that order. I mean, by the time this lady takes off her socks, it may already be violet or purple, but this description that I've just given before you is written in books as erythromelalgia, and you would have read about this manifestation in a disorder by the name of polycythemia vera. Yes, the same disorder which we study in the literature of myeloproliferative disorders, JAK2 mutation. And another feature of polycythemia vera which has been asked, and I can just mention at the moment because I'm getting an opportunity to talk about this disorder, is aquagenic pruritus. This patient, the moment he or she will take a bath, especially with warm water, it would cause a mast cell degranulation, causing extensive itching all over the body. Very characteristic terminologies I've just highlighted before you. Aquagenic pruritus and erythromelalgia are features of polycythemia vera. Why are they discussed at the moment? Mainly to highlight that in the lower extremities we are talking about some excessive redness to the level that person is using a violet discoloration of the toes. That's definitely a feature of this myeloproliferative. But if you're having a lady who says that whenever she's taking a bath with cold water and her toes are changing color from white, blue, red, mark my words there, Raynaud's phenomenon can not only be present in the upper limbs but can be present in the lower limbs as well. So don't be under impression that Raynaud's is exclusively a manifestation of upper limb and cannot be seen in the lower limb. And do not mix up this information with that of Burgess disease, because that will always be having information regarding intermittent claudication, arterial ulcer, and then maybe a gangrene development where the toes will become relatively black. I also want to highlight an investigation that sometimes might be written in the book to describe Raynaud's phenomenon features. You see, the color sequence is obviously white, blue, red, but the investigation that is done to evaluate patients with Raynaud's phenomenon is called as nail fold capillaroscopy. Well, we can be using a ophthalmoscope. Looks surprising, but we can use a ophthalmoscope to evaluate the capillaries just close to the nail cuticle. In a normal person, the capillary loops are, as you can see, are pretty close together, but in especially Raynaud's phenomenon related to scleroderma, these capillary loops are separated more than each other, and there might be intervening fibrosis as well. You see, there is fibrosis across the smaller blood vessels, so that is distorting the autoregulation of the blood supply of the fingers and the toes, which is contributing to secondary Raynaud's phenomenon. I repeat once again, systemic sclerosis has a secondary Raynaud's phenomenon and a very characteristic manifestation. Rather, it is one of the common manifestations. I'll also speak about which is the commonest manifestation, but one of the common manifestations is Raynaud's phenomenon. Now, in some questions, he might just say which is overall the most common involvement seen in systemic sclerosis. Then overall the most common involvement should be answered as skin involvement. When I say skin involvement, the usual queries are what will the skin manifestation show up as? I mean, is not Raynaud's phenomenon a skin manifestation? Yeah, the manifestations are appearing in the tips of the fingers. That's also skin, related to skin only. But the characteristic terminology that I want you to remember for this disease is called as leather-like skin. I mean, lots of these rheumatic disorders, no, per se will be having so much of information given in a question spanning over 5 to 10 lines sometimes that you might get bogged down reading the question under 1 minute. You see, you have to not only read the question, but at the same time analyze the options and then select the correct options. And it could be more than one correct option to be selected as well. So you always need to pick up some key words, like a question begins with a female patient, positive antinuclear antibody, and then talks about leather-like skin. You know that you just need to search for the antibody which will confirm the diagnosis as scleroderma. This leather-like skin manifestation might sometimes deliberately be written as sclerodactyly. Now what's going to happen in sclerodactyly will be one, there would be contractures developing in the hand, so range of movement will substantially be reduced. In fact, sometimes he might use a very interesting terminology to describe this fibrosis occurring below the skin. He might use the word tendon friction rub. You see, normally we read about a pericardial friction rub and a plural rub, but tendon friction rub, that's noise when you are using, fingers per se. That is because of the fibrosis related to the tendons in the hand also. So there are various ways the examiner can describe this skin manifestation. The terms used are leather-like skin, very classical. Sclerodactyly, he would usually not write. I personally feel that because you see, the moment he will write the word sclero, right, you know that it is scleroderma or something related to scleroderma, so you get a bit of idea. So he'll try to beat around the bush, like writing features like contractures or tendon friction rubs per se, or talking about digital ulcers, because then you would be thinking about, even from the surgical domain, that it could be a blood vessel disease, it could be related to small blood vessels, it could be related to thromboangiitis obliterans as well. In fact, in some cases, a very characteristic manifestation might even occur, that is pitting of the tips of the fingers. You see, this is what I'm saying. If this is the representation of the tip of the finger, you could be having some fibrotic bands developing in the tip of the finger. Along with this, even the changes in the terminal phalanx are seen. You see, the blood supply of the distal area is getting affected, so even the terminal phalanx gets affected sometimes. So when you examine this patient, you might be having some pitting scars in the tip of the finger. Either he might use the word simply pits, or he might just say pitting scars in the tip of the finger. In fact, I can explain like this, like in surgery, when you're reading breast cancer, you read about Pude orange. You see, the cancer infiltrates into the skin of the breast and it causes pitting scars. Similarly, pits in the tips of the fingers. This is the volar aspect of my finger. So pits in the volar aspect of the finger will develop again because of this extensive fibrosis, along with damage to the blood supply of the terminal phalanx, blood supply of the skin of the tip of the finger. So all of these combined will contribute to these atrophic changes. Another feature that you can understand from the fibrosis component is that, you see, if I'm ordering a burger from McDonald's, let me say I order a chicken maha burger, right, or a paneer burger, but the point is the burger is relatively big, so you need to hold it, then open your mouth wide and then bite into a burger. Now if this lady is having fibrosis around her lips, because there's going to be fibrosis everywhere, so there's a possibility that if there's fibrosis around the lips, she may not be able to open her mouth properly. So microstomia might describe a feature which is very characteristic for diagnosis of this disease. Or he might use the word pinched facies. You see, I've described per se facies or various varieties in neurology, but in rheumatology, if it comes to facies, I want you to remember this terminology, which are good hints towards the diagnosis of this particular disease. As the fibrosis will progress inside the mouth, there's a possibility that the salivary glands, both the major one as well as the minor ones, are getting affected. As a result of it, the saliva production will reduce. Saliva will cause lubrication of food. In this case, the lubrication food will be substantially affected. So therefore, especially when the person is eating dry food items. Dry food items examples I can give is like chips or for example biscuits. You see, if you have a dry mouth and you try eating a biscuit, it will stick to a hard palate. You eat chips or crackers, they'll stick to a hard palate. You might have to drink water so that you can push it down. Right, might have happened, especially as a kid, you're hungry, you're suddenly gorging on biscuits. They tend to stick in the hard palate if your mouth is dry. So dry food items are a definitive no-no for this person, or if the person is not perceiving this, then he or she, mainly will be a she, will say that I am having difficulty in swallowing. This oropharyngeal dysphagia is the primary complaint of this lady who's having fibrosis of her salivary glands also. After all the manifestations of the disease is related to the fibrosis component. Another feature that is again easily identifiable on MCQs would be esophageal dysmotility. Now here, because he will describe a female with difficulty in swallowing, so you might get a special bias towards HLA-cardia, because HLA-cardia is again common in young females. I've explained in GI tract, it is autoimmune etiology. All autoimmune disorders are common in women. So I have seen a lot of guys casually marking HLA-cardia in the description without focusing on the terms that I've told earlier. I also want to tell you that suppose you can't remember all of this and you say, sir, how can I remember so much? Then you definitely need to pay attention to the question, because he will definitely talk about manometry report. In HLA-cardia, because there is loss of inhibitory neurons or the inhibitory ganglia, the end result is increase in the tone of the lower esophageal sphincter. But in this case, because there is a fibrosis in the sphincter, mark my words there, HLA-cardia will always be having an increase in the tone of the LES. I have explained that even in the GI section, but in this particular case, there would be a reduction in the tone of the LES, resulting in GERD manifestations. This gives him even more leverage, because now he can be talking about features like sour brash, or when this acid will come in the mouth, it will damage the molar teeth. So dental enamel damage or spots on the teeth could be present, retrostral pain could be present, it could be chemical tracheitis, it could be chemical laryngitis. So person will have sore throat, person will have night cough developing because of the chemical tracheitis component. So it gives a huge leverage to any examiner to waste your time by expanding the length of the question. Now I'm going to talk about bad prognosis that would be subsequently occurring, which is that lungs will start getting involved and pulmonary fibrosis will occur. Here I've seen people mixing this up with shrinking lung syndrome. I have already explained to you that shrinking lung syndrome per se is a terminology that you use with systemic lupus erythematosus. Here all I'm saying is there's a pulmonary fibrosis. So now the bad news is that he can definitely quiz you regarding timed vital capacity and spirometric parameters as well. You see, that is the problem with rheumatology. There is so much of multi-system involvement that he can incorporate literally everything that you study in the domain of general medicine. Spirometric finding of this guy is going to be a reduction of the residual volume due to shrinkage of the size of the lung with enhanced timed vital capacity. Then there could be fibrosis occurring even in the pulmonary artery. There could be pulmonary artery hypertension. There are two reasons for pulmonary artery hypertension in this chap. One is pulmonary fibrosis will cause hypoxia, and hypoxia as a stimulus causes dilation of all blood vessels except pulmonary artery. The pulmonary artery will not dilate, it will constrict. So therefore the pulmonary artery pressure will start rising in this case. I also want to tell you that per se, not only hypoxia, even the fibrosis will extend to the pulmonary artery wall also. So there are two reasons. One is the hypoxia component causing pulmonary artery hypertension. Second is the fibrosis per se contributing to pulmonary artery hypertension, which explains the fact that why pulmonary artery hypertension is the leading cause of death. Now here I just want to say that you see in Harrison, he has written it such a fashion that lots of you might actually take snapshots and say, sir, even in pulmonary fibrosis is written leading cause of death. He has written leading cause of death for both of them, but mortality where he has written 30% mortality, that he has written for pulmonary artery hypertension. So the most common cause of mortality in this case is to be answered as PAH. and well, he can write this as loud P2. The murmur that will occur here will be a early diastolic murmur, or he can write it as reduction in DLCO. So the examiner is again getting a lot of leverage to ask you about all these parameters. The fibrosis of this patient can even extend to the heart and can result in restrictive cardiomyopathy, which could be written in the form of this person exhibiting a Kussmaul sign, which is going to be a paradoxical rise of JVP on inspiration. Traditionally, it would fall. Even the kidneys will begin to shrink, so there would be a progressive reduction in GFR. This is going to contribute to progressive rise in the value of renin, and higher is the value of renin, the end result would be blood pressure of this person will serially start increasing. You see, when you have a patient of essential hypertension, if BP is elevated, it remains usually at that level, does not fluctuate much. But in this case, what is happening is that the blood pressure is increasing on month and month basis as the kidney is progressively shrinking. On a progressive basis, there is a rise in blood pressure of this person to the level that you are having to increase the dose of antihypertensives on a regular follow-up. The description that I'm giving you at the moment is that of malignant hypertension, which is also referred to as scleroderma crisis. And on reading this terminology in multiple choice questions, I've seen people getting biased because the moment you read the word crisis written, you think that that is the leading cause of death. I've already sensitized you to the fact that the leading cause of death in patients who are suffering from scleroderma is first pulmonary artery hypertension, followed by interstitial lung disease, because pulmonary artery hypertension is occurring because of interstitial lung disease. And yes, scleroderma crisis can also contribute to mortality if not treated. Here also bias comes. You see, people start answering sodium nitroprusside or other fancy drugs, intravenous ones, for management of this scleroderma crisis, assuming that this is a standard case of malignant hypertension. Yes, we use parenteral drugs for malignant hypertension, but here the problem is you can't give parenteral drugs daily, no. So you will anyway have to continuously increase the dose of ACE inhibitors for these patients. If he says what is the drug of choice for scleroderma crisis, your answer should be given as ACE inhibitors and not the standard fancy drugs. Now here I would like to give some additional information to you before we go a little forwards per se, so please remember the current information that I tell you very carefully. This has been highlighted in the earlier part of our discussion as well. So suppose a person is having hypertension and ended up with development of stroke. In these circumstances, it's important to lower the BP of the patient, otherwise the bleed can be pretty substantial or it can even increase. So in a documented case of stroke, the drug that is recommended is nicardipine. On the other hand, when you are finding a patient with very high blood pressure during pheochromocytoma surgery, you see there's gonna be spike of catecholamines in the blood. As they will rise further, they contribute to vasoconstriction. The exaggerated vasoconstriction will spike the BP to dramatically higher values like 250 by 150. So what are you gonna use in surgery? You're gonna use sodium nitroprusside. I want to highlight that this scenario that I described before you, intraoperative hypertension occurring during pheochromocytomy, we can be using sodium nitroprusside because then you can even handle the pulmonary edema component that might occur because of very high blood pressure. The left ventricle is anyway gonna get compromised. In cases of hypertension during delivery or at the time of labor pains, we call it eclampsia, and she can spiral out of control in a sense that she can even have seizures. So for seizures, we'll definitely be giving magnesium sulfate, but for control of the hypertensive crisis at the time of pregnancy, that is eclampsia, we use labetalol. All this information has already been shared with you in the various lectures in the previous part of the app. I just wanted to summarize and highlight the fact that scleroderma crisis word makes you feel biased, but you need to just remember that ACE inhibitor would be the primary answers here. Also, when it comes to leading cause of death in patients with SLE, there have been various different answers that I have provided. So I'll just make you practice that again before we go forwards. In a patient of SLE with active lupus, I mean, there is no treatment done at the moment. It is the kidney related mortality, which is the primary cause. I mean, end stage renal disease. And the only way out of this mess is a kidney transplantation. However, the same patient of SLE, if was treated, and in the first decade of diagnosis itself, like she was diagnosed at 25, she's dying by 35, it's due to the side effect of the high potency steroids that you are using. Plus in SLE, the antibodies can attack self lymphocytes causing lymphopenia as well. The same patient of SLE has survived all this. She's a fighter. She has been very regular in the follow-ups, and like you know her for, let me say, last 10 years. She has been under your follow-up. Now she's beyond 45 years of age. At this point of time, there's a cardiovascular mortality incidence that's gonna spike. The reason for increase in cardiovascular mortality at this particular age would be primarily due to accelerated atherosclerosis. I said the same thing in cases of rheumatoid arthritis. As these patients will start growing older, it is the cardiovascular mortality that comes up. But when it comes to a question on scleroderma, and the question says, irrespective of the age group, what is the leading cause of mortality? It is pulmonary artery hypertension and pulmonary fibrosis, which are going to be blamed for it. If both are given, great. If not, then select pulmonary artery hypertension, because that is the number one mortality contributor given with a percentage in the textbook. All the information that is provided in this box is related to mortality to various rheumatological disorders. And why does he ask you about this mortality? Is because he wants to know whether you know that which organ is very vulnerable in these diseases if they're not treated properly. So let us recap the data. If the question begins by describing a female patient with anti-nuclear antibody positive and then talks about so many clinical manifestations, there's a distinct possibility that at the end of reading that 5-line MCQ, you might be tired and may not be able to make out anything, because it's not possible to remember everything. So I want you to remember the core issues in rheumatology is to get the antibody right. Most guys score very easily in rheumat, primarily because the antibody can be remembered here. If you read regarding anti-topoisomerase 1 antibody per se, and along with this other features that are described are given, then you know that the diagnosis is to be given as systemic sclerosis or the diffuse variety of scleroderma. What are the features which are usually asked? Though I described many of them to you, I'll just focus on the important ones. One is secondary Raynaud's phenomenon, which may or may not be associated with digital ulcers. If it is not treated, if it's not diagnosed, then yes, digital ulcers in the tips of fingers can be present. One of the very good ways to identify this condition is word sclerodactyly. If not given, it could be leather-like skin, it could be pitting scars which could be present in the tips of the fingers of this person. Then could be pulmonary artery hypertension in the later stages. Well, how does the examiner write PAH? He's not going to write PAH and serve the question on a platter to you, right? So he's going to write reduced DLCO was found on the workup of this lady who was found to be having breathlessness on climbing stairs. And a spirometry shows that a timed vital capacity is increased and a residual volume is reduced. So he is implying that when you read this information, you are understanding that this is going to be pulmonary fibrosis. If he gives up the information of malignant hypertension, you know that you are bang on spot as diagnosis as systemic variety of scleroderma. But even if you don't remember this, guys, then anti-topoisomerase 1 antibody will do the trick for you. Well, for the treatment of this condition, he says case-based approach should be used. I mean, we cannot say that one particular drug is the drug of choice for this condition. So it's going to be combination. It's going to be steroids. We can use methotrexate, the standard drugs that are used in rheumatoid, and cyclophosphamide has been shown to have good results for management of this condition. Obviously, the side effects like hemorrhagic cystitis have to be kept in mind. Now we will compare this particular manifestation with a related MCQ, which will again just begin by describing a female patient with positive anti-nuclear antibody, but then will describe features of calcinosis cutis. Well, what is so special about this term calcinosis cutis? As the name suggests, it's going to be calcification in the skin. But the meaning of this terminology, I mean, why is it so important about calcification in the skin, is because the calcification is occurring in spite of the fact that there's going to be normal calcium and normal phosphate. Traditionally, calcium or phosphate, either of the two should be high. That is when we get calcification of the skin. But in this case, the highlight is that in spite of normal serum calcium, normal phosphate, still there is salt deposition and formation of hard chalky plaques, which are extremely painful. Additional feature that can be present is Raynaud's phenomenon. I mean, I have already highlighted primary versus secondary. Now I want to tell you that Raynaud's phenomenon can be present even in a case of SLE also, but the prevalence is relatively lesser, unlike the current topic that we're discussing, scleroderma, where the prevalence is much higher. Another feature that I've highlighted, and I'm writing once again, is patient having esophageal dysmotility. So this would be a progressive manifestation and can contribute to confusion with HLA-cardia. The standard feature of leather-like skin may not be written. He might just say the word sclerodactyly or vice versa, or tendon friction rubs, as I've explained. An additional term that I'm now introducing is dilated blood vessels, that is telangiectasias. These telangiectasias can be seen anywhere. They can be seen on the face, or maybe they might be seen in the white of the eye. Like you see, I'm sitting at a distance from the camera, so you can obviously see the white of my eye, that is the sclera, but you can't see the fine blood vessels in it. But in this case, you definitely be able to identify the blood vessels even in the sclera per se, which can be seen as a thick leash of vessels. So telangiectasias can be present at multiple sites. What I am leading you here is towards a diagnosis of CREST syndrome. And for you to solve this, either you have to remember the full form as I enumerated before you, or I can give you a shortcut. The shortcut is the name of this antibody, that is anti-centromere antibody. If you just get the names right, you are bang on spot for diagnosis of various rheumatological disorders. This particular description that I have just given you can also be written as limited cutaneous scleroderma. It can be written as LC. Lots of time you will read questions saying diffuse cutaneous. That's going to be systemic sclerosis. I mean, if you just go by English, not diffuse cutaneous, because multiple manifestations. This time I've written only few before you. So limited cutaneous systemic sclerosis, or like this, he might write the word LCSSC. So you need to get used to the short terms. It is limited cutaneous systemic sclerosis that we're talking about at the moment, where even the calcinosis cutis concept has come up. Now I'll describe a case before you which will have very strange presentation. Why? Because he will describe a female patient with anti-nuclear antibody, then will describe a malar rash, so you will be biased towards thinking that this could be SLE. Then he will describe Raynaud's phenomenon. As I've told you, Raynaud's phenomenon can be seen not only in scleroderma but even in SLE. So you are now thinking, is it SLE, is it scleroderma? I need more information in the question. Then he will surprise you by describing that this lady is having pain in the small joints of the hand, proximal interphalangeal, metacarpophalangeal, and wrist joint getting involved. That too bilaterally. I mean, please appreciate, bilateral involvement of small joints of the hands was discussed in rheumatoid arthritis. Then he's also describing that this lady is having difficulty in climbing of stairs. She's having features of polymyositis. He can describe it by writing either the word proximal muscle weakness, or he can describe that when she's climbing stairs, she has to take the support of the railing, and she says, earlier I could go up and down my house multiple times per day, but now it's a Herculean task for me. So you can see here that one, features of SLE have also been described in the case. Rheumatoid arthritis features have also been described. Polymyositis features have also been described. So you can just remember SPR, combination of SLE, polymyositis, and rheumatoid arthritis features. These entire information will be given by you as an answer as MCTD, that is mixed connective tissue disorder. Now, most guys, when I describe this, no, they start saying, sir, difficult to remember. Can't you have a simpler and a shorter way to remember this? Yes, I do have it. The name of the antibody will again be the saving grace in this case. Well, this time the name of the antibody that you need to remember is called as U1-RNP antibody, and I've sensitized you to this even when I discussed SLE, because I was teaching psychosis in SLE caused by anti-ribosomal P. That's the usual point where people tend to mess up, because anti-ribosomal P was discussed for psychosis in SLE. Name is rhyming, no, R ribosomal, now RNP. This time the RNP stands for ribonucleoprotein. So if you get the antibodies right, as I have highlighted, that would definitely help you in cracking these questions. Please do not confuse this with U3-RNP. You can see, is it in the exam? U1 and U3-RNP can definitely be confused. So U3-RNP would be antibody against this component that is called as fibrillarin. And well, this antibody can be seen in both limited cutaneous systemic sclerosis as well as diffuse cutaneous systemic sclerosis. Diffuse cutaneous was the initial manifestation that I described in this topic per se, where I talked about even the kidney involvement, digital ulcers. Everything that I described in the starting of the disease was systemic sclerosis, that is called as diffuse cutaneous. And when I described CREST syndrome, that was limited cutaneous systemic sclerosis. This antibody is only to trouble you in the exam. Even if you don't remember this information of U3-RNP, it is okay, because what you need to remember for the exam is U1-RNP. This was only to sensitize you to the closely matching terminologies. I have today also tried to explain manifestations of diffuse versus limited, and I would like to finish this discussion by now writing localized scleroderma. Well, this is a term from dermatology, but still I would like to share it before you because this would be having a scar that would be idiopathically appearing on the face and can cause disfigurement. The question will simply say, what is localized scleroderma? Your answer would be morphia. That's the term that I want you to remember. What it basically means is that without any injury, multiple scars could be appearing on the skin of the patient. That will definitely cause a disfigurement, but per se in this localized variety you would not be having whatever earlier manifestations have been described for this topic. So these are the details I want you to remember for the topic per se, and as I have highlighted, I mean, the antibodies are right, everything will fall into place. Thank you so much for hearing me out.